Good evening, ladies and gentlemen, and welcome to what is the 6th Dean's Lecture for 2022. My name is Lindsay Odes, and I am delighted to be hosting the Dean's Lecture tonight in Professor Jim Waterston's, I'll get his name right, it's my boss, Jim Waterston's absence. I'd like to start by acknowledging the traditional owners of this land, the Wurundjeri people, the custodians of this land, and I pay respect to the elders both past and present and to other Indigenous Australians present. I also acknowledge the place of Indigenous knowledges in the Academy. And this brings me to the important part of the evening, introducing our guests. So firstly, I'm a wellbeing scientist, and I've been actually hoping to meet our guest for several months, and so tonight was a great opportunity to do that. But I have been particularly looking forward to this evening and listening to Professor Frank Oberklaid about what he has to say. He is a leading paediatrician and expert in children's health, development, and something dear to my heart, wellbeing. And I know our Dean, Professor Jim Waterston, is disappointed to be missing tonight's lecture, given MGSC's close work with Professor Frank Oberklaid, and particularly in recent times. Some of you may have listened to Jim and Frank's chat on our latest Talking Teaching podcast, where they discuss the Mental Health in Primary School, or MIPS, project. Professor Oberklaid, alongside partners from MGSC and the Victorian Department of Education, was a pivotal figure in the development of this program. And for those of you who aren't familiar with the Mental Health in Primary Schools program, it helps to build the capacity of Victorian primary schools to support the mental health and wellbeing of students, address mental health problems in children before they enter adolescence. If you haven't heard their discussion and would like to listen to the podcast later, simply Google MGSC Talking Teaching Frank Oberklaid and it will come up for you. Now, if I give a more formal introduction to our guest speaker this evening. Some people like to cut this out because they don't like people's long bios, and Frank's probably one of them, but you don't get these sort of bios easily, so I'm going to pay respect to it. So Professor Frank Oberklaid was the Foundation Director of the Centre for Community Child Health at the Royal Children's Hospital, Melbourne. I was just talking to Frank earlier how I live straight across from there and hear your helicopters, so thank you for that. He is currently Co-Group Leader of Child Health Policy, Equity and Translation at the Murdoch Children's Research Institute. Professor Oberklaid has written 2 books and over 150 papers in scientific journals. Is there anyone here who would like to have 150 papers? I know some of us would. He has a long-standing clinical research and policy interests in children's health, development and wellbeing, and has chaired or been a member of numerous expert working groups at a state, national and international level, as well as being a consultant for the World Health Organization and UNICEF. Most recently, Professor Oberklaid was co-chair of the National Child Mental Health and Wellbeing Strategy, which outlines a detailed policy and service framework for child mental health in Australia. And I remember the day I was in Canberra and Greg Hunt announced that, and I was so pleased to hear of that initiative. Professor Oberklaid's work has been recognised by a number of prestigious awards, and he has been the recipient of invited lectureships and visiting professor appointments in over 20 countries. Tonight we're fortunate to hear Professor Oberklaid, or Frank, discuss how the current service system to address child health issues is no longer fit for purpose. And I'm very interested in hearing this, and argue that we must redesign the system to get better results, that primary schools occupy a unique role in helping to detect health issues in our children, to assist in prevention, early detection and intervention. So without further ado, could you please join me with a big warm welcome, Frank Oberklaid, to the stage to deliver our lecture, Schools as Community Service Platforms. Welcome, Frank.
Thank you. Thanks very much, Lindsay, for that very generous introduction. I also would like to begin by acknowledging the traditional owners of the land in which we gathered tonight, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging. Represents the stereotype of an Australian, laid back, relaxed, no worries in the world. And an ex-Prime Minister a number of years ago, when he was asked his vision for Australia, if you recall, said he wanted Australians to be relaxed. And you can interpret that as steady as she goes, or business as usual, or don't rock the boat, don't change things, because change brings with it inevitably non-relaxation. It brings with it all sorts of anxieties and agitation, etc. But I'm going to put to you tonight that some things do need to change. You will know Brian Caldwell as the Dean of the Melbourne School of Education a number of years ago, and he wrote a book in 1990 called Challenges for the 21st Century, and he introduced me to this quote from Drucker. Drucker was an American guy who lived in Japan for a number of years and examined the Toyota system of excellence, of continuous quality improvement, brought that back to the States and popularised it in America and in the Western world. I like this term, organised abandonment. Drucker calls for organised abandonment of products, services, markets or processes, and I quote, which were designed in the past and which were highly successful even to the present, but which would not be designed in the same way if we're starting afresh today, knowing the terrain ahead. So why can't it be business as usual? And the answer is that we've got worsening child outcomes. This is from Fiona Stanley and Richardson Pryor a long time ago, 2007. I would suggest that it hasn't improved since then. If anything, it's got worse. And Fiona has said, and I'm sure she's correct, this is the first generation of children and young people who are worse off than previous generations. In a whole range of outcomes, they're worse than in previous years. So this is contemporary paediatric morbidity in numbers. And you can see just the sheer numbers of children with obesity, mental health problems, 350,000 notifications for child abuse last year. 60,000 children start school developmentally vulnerable in one or more areas of development. Just huge, huge numbers and not getting any better. And we're seeing increases in autism and ADHD and a whole range of other problems. This quote you'll be aware of, every system is perfectly designed to get the results it gets. So it follows then, to get better results than the previous slide, we have to redesign the system, that adding little band-aids and patches here and there ain't going to do it. So what I'd like to do tonight is talk about, from a paediatrician's point of view, how paediatric morbidity patterns have changed in the last several decades, some of the emerging research on child development and the impact on outcomes, brain development in the life course, adversity, social climate change. Put to you that the service system we've got now in Victoria in the community is no longer fit for purpose. It was designed generations ago for issues at the time, but given the contemporary needs of children and families, it doesn't fit anymore. Talk about the new models in schools and argue that we need to think outside the box. And out of respect for the education sector, because I'm not an educator, I pose the last thing as a question mark, a leadership role for the education sector, but I think it should be an assertion. I think there's a really major leadership and advocacy role for education in moving outside the school, outside education, and trying to make a difference for all children. So paediatrics 50 years ago was focused on illness, treating sick kids, largely in hospital settings. Health was defined as the absence of illness. You're healthy if you weren't sick. It was as binary as that. Clinical practice was focused, as I said, on treating disease. There was a real lack of sophistication about well-being and mental health issues. So we did a physical examination. If we couldn't find anything, it must be emotional, and we refer to psychiatry. And the community was where patients came from. Otherwise, there was no relationship with anything in the community. And that changed with Bob Haggerty and his colleagues, who published this very seminal book called Child Health in the Community. And he was the forerunner of a sea change in paediatrics, the evolution of paediatrics into where it is today. So he argued at the time, 1975, health is affected by environmental and social processes as well as by sociological factors. The community in which a child lives is a major determinant of his health. Although such statements are widely accepted intellectually today, they're not yet reflected in our healthcare institutions. And then he goes on in the same book to say a group of childhood difficulties that we have termed the new morbidity is now gaining attention. Many of these difficulties lie beyond the boundaries of traditional medical care. A major shift in the orientation of training programs is required. And he argues then for an increased focus on prevention, early intervention, community, and that's how paediatric practice has evolved. A major shift in the pendulum away from just treating sick children towards prevention, working with other professionals, etc., etc. So this is the new morbidity. It's a partial list. And these are kids that you see in the classroom. These are children who attend school. So teachers deal with them every day of the week. These are data from Harriet Hiscock. She studied the referrals of new patients to paediatricians. And you can see 8 out of the top 10 diagnoses have to do with this new morbidity. So it's real. Paediatric practice has changed radically in the last 30, 40 years. So contemporary paediatric morbidity may have a biological underpinning. There may be a genetic predisposition, but the way conditions unfold are largely environmental, and Clyde Hertzman calls this the biological embedding of environmental events. It's intergenerational, it's complex, it's strongly associated with disadvantage, and it's described in the literature. These children present with what are called wicked problems. So the old paradigm of a single professional assessing, making a diagnosis, treating, doesn't apply anymore. So as I said before, it's just as relevant for the education sector. The work I do with teachers in schools, they're in the classroom, and many teachers don't feel well equipped to deal with them. So then, in the last 3 decades, community child health has emerged, again, arguing for a broadening of paediatric practice. So each of these terms is important. A comprehensive system of healthcare, not a hospital, not a community health centre, responsible for promoting the health and development, not treating illness, of all children within the context of their family and community. So it's multi-sectoral and multidisciplinary. Public policy and health delivery extends beyond the traditional health sector, different government agencies, and importantly, different settings, not just hospitals and doctors and community nurses, but kindergartens, schools, childcare centres. In other words, healthcare needs to be delivered where children are, and they're not in hospital settings, and they're not always in doctor's surgeries. So the College of Paediatrics a number of years ago, a long time ago now, introduced a mandatory period of training in community child health. The clinical practice of community child health is developmental behavioural paediatrics. So in Australia now, you cannot become a paediatrician without being trained in the new morbidity. And there were teething problems, there were some barriers, there weren't enough physicians, there weren't enough supervisors, etc. That's all ironed out now. Last year in our centre, we have a big training program. I think we had close to 30 applicants for 8 positions. So people want to be trained in this area. The new morbidity in education hasn't been well described to the best of my knowledge. A number of years ago, 2004, I published an editorial in response to a paper written by Michael O'Keefe and Michael McDowell, who surveyed teachers in Brisbane schools and found that a lot of them had misconceptions about the new morbidity. Conditions like ADHD, mental health issues, ASD, their knowledge base was low. Furthermore, they didn't feel confident in dealing with these. Furthermore, they'd made very little contact with paediatricians and other healthcare people. So my editorial was really a call to paediatricians to understand that many teachers had these gaps in their training And when we wrote reports to make them accessible, not to use jargon, to try and talk about the classroom implications of chronic illness or developmental issues. And there was also a call to arms about, or a challenge for the education sector to start training a little bit differently. Then mental health. We've known about this for several decades as well. Michael Sawyer and his colleagues in 2000 did the first national survey on mental health issues. And I asked 3 questions of the respondents. How many children and adolescents in Australia have mental health problems? What's the nature of those problems? What's the degree of disability? And what are the services that they use? And these are the data. Then more than 500,000 children and young people in Australia had mental health issues using a reliable survey methodology. And I would suspect, particularly post-COVID, that number has increased substantially. And what was concerning is only 1 in 4 of these children with mental health problems received help. And only 50% of children with the most severe problems received help. That's despite the fact the literature suggests that 50% of adult mental health problems start in childhood. Or put another way, 50% of children's mental health problems continue into adult life. So we're missing all these opportunities to try and intervene earlier before we see established problems later in life. And Michael goes on to quote, the relatively large number of young people with mental health problems stands in contrast to the limited number of trained clinicians available to them. This disparity makes it unlikely that specialised programs based in secondary and tertiary treatment settings will ever be able to provide direct care for all those with problems. As a result, there's a need to experiment with alternative models of service delivery that combine direct care, consultation to primary health care or school-based services, and both universal and targeted programs. Not much has happened up until recent years. We used to describe child mental health as the elephant in the room because it just kept getting ignored. Why has it been so hard? Why have policy people found it so hard to focus on child mental health? And this is an even older quote from Lionel Sachs. Children's mental health problems reflect unique interactions between intra-individual difficulties and environmental conditions. Treatment must therefore address conditions in the family, school and neighbourhood as well as the child. This requires a system with a diverse set of interventions and the capacity to coordinate multiple services. And I'll come back in a few minutes to talk about coordination. So we know that child mental health is a different country. I've been to endless meetings where I've tried to argue that child and adolescent mental health is not the one word. Child and adolescent, hang on, child mental health is a different country completely. Children are dependent. The development means that symptoms vary with age. And we're missing all these opportunities for prevention because young children are making contact frequently with MCH nurses, with childcare centres, with GPs, with schools. There's so many opportunities to move the dial towards prevention and early intervention. But all that creates complexity. And governments don't like complexity. It's this complexity of child mental health that's been one of the major barriers to getting good policy. For every complex problem, there's an answer that is clear, simple, and wrong. Governments don't deal well with complexity. One of my staff said to me ages ago, for government, it's got to be as simple as add water and mix. And this is not a reflection on government, it's the way governments are organised. And no other country does it any better than Australia necessarily. But integrating policy across departments is very, very challenging. There's fragmentation of policy, as you'll see in a moment. And prevention is a very hard sell. That policymakers and politicians like edifices. They like to build things or announce things because there are opportunities for a plaque on the side, there's some media coverage, etc. You can't take policymakers into a school and show them prevention. It's invisible and it's a long-term. So there's other research that makes it imperative in my mind for an increased focus on children. The Brain Development and Life course, our understanding of how important the environment is and parent relationships, the the impact of stress and adverse childhood events. I'd like to briefly just go through those. The neuroscience of early childhood is known to all of you. We understand now that the early years before a child goes to school are critically important in setting the foundations for lifelong learning and lifelong health. And we're very clear about exactly the sort of conditions that a child needs in an environment growing up that pose a risk to that development, and conversely, exactly what a child needs to thrive and prosper. And what happens over time is the plasticity of the brain decreases and it gets harder and harder to change. So any of you in the audience that have tried to pick up a skill as an adult, whether it's a language, a musical instrument, a sport, you can do it, but it's difficult because the plasticity of the brain is so much less than when it was when we were 3 and 5. So the research is very clear that biologically and economically, it makes much more sense to get right the first time than to go back later on and try and fix things up. And in our country, because we've dealt with nutritional issues, safety is generally not a concern, we have high immunisation rates, so we can protect children from infection. The single most important environmental factor in determining outcome is the quality of the relationships that young children have with parents and with caregivers. So nurturing and responsive relationships help build the foundations of a sound life course. When those protective relationships aren't provided, stress levels and inflammatory products go up in the child's brain, and where there's persistently high stress levels, there's persistently high cortisol and inflammatory products, and that interferes very significantly with optimal brain development. So dysfunctional relationships pose a very major risk to child development and pose a major risk to life course. So we know that adversity affects the developing brain through this stress response, and there's a partial list of these. All of these risk factors are more common in low SES groups. They're all more common in disadvantaged families. So adversity and poverty and disadvantage, as I said, is mediated through this stress response, has a major impact in the early years, and chronic stress resets the body's physiological and immune systems, resets them in a way so they become much more vulnerable as that child grows up to a whole range of conditions. And these kids experience what I call double jeopardy. These are kids that would benefit the most from going to high quality childcare, high quality early learning, tend not to go. These are parents that would benefit the most from having access to psychosocial support and are the least likely to avail themselves of that. And this is called the inverse care law. It's well described in public health circles. So disadvantage appears very early on, even during pregnancy, higher rates of smoking, higher rates of low birth weight, etc. This is Hart and Risley's study. This is probably the most shown slide in the world. Everybody shows this slide. Hart and Risley's longitudinal study of vocabulary. You can see children start off with around about the same potential, even allowing for individual differences in genetics. By the time these children are 3, look at the differences in vocab between children in high SES and children in low SES. And because the plasticity of the brain decreases over time, these differences are going to become entrenched. They're not going to narrow at all. And these are Australian data from the longitudinal study of Australian children. You can see that in each of these domains, social emotional difficulties, communication, emergent literacy, vocab, around about the age of 3 or 4, we're starting to see differences between advantaged children and disadvantaged children. Then by the time they get to school, they're really well entrenched. You'll all be familiar with the Australian Early Developmental Census. It's a population measure of children's development and well-being that teachers complete in the first year of a child's formal schooling, about 100 questions. These are the domains: social competence, emotional maturity, language and cognitive development, and physical health and well-being. Results are provided at the school postcode level. We don't analyse for individual children. And in 2018, almost 1 in 4 Australian children arrived at school delayed or immature in one or more areas of development. And that puts them at risk of a poor school experience. So what we're asking schools to do is to compensate for what's happened to in those 5 years before the kids even get to school. So the strongest support when we were launching this many years ago now was from principals from the education sector, because when the school got criticised about poor reading results, they said, no, look at the shape these children were in before they came to us. And this is what I was mentioning before. These are well-known data. You can see the most disadvantaged children have a much higher risk of arriving at school already in trouble. This is the inverse care law. We'd want disadvantaged children to go to early learning, but are the least likely to go. And then there's double whammy. If you come from a disadvantaged family and you don't go to childcare, you've got a significantly higher risk of arriving at school with problems. James Heckman is a Nobel Prize-winning economist who now goes around the world arguing for increased investment in early childhood, simply on data. He's not a bleeding heart like we are, because we work with children. He looks dispassionately at data. Once a child falls behind, he or she is likely to remain behind. Impoverished early environments are powerful predictors of adult failure on a number of social and economic dimensions. And these are adult problems with roots in early childhood. For many, many people with these sorts of conditions, we can trace back to those early years and identify the pathways to these. And this list is growing all the time. This is robust research now. And not just psychosocial and mental health issues, but organic conditions like heart disease, high blood pressure, stroke, etc., etc. And then there's been a flurry of research into the adverse childhood events. This started the first paper was written in 1985. The San Diego Kaiser Center is a health maintenance center in California who keep very, very good records. And the researchers looked at adult populations and went back looking at what happened in those early years. So these are the adverse events in childhood. We would see all of these, except maybe incarceration. We don't have incarceration rates like they do in America. And these are the results. If you had 4 adverse childhood events, you had an increased risk of alcohol use, poor self-related health, cancer, heart disease, respiratory disease, the list just goes on and on. So there's a very clear relationship with prospective and retrospective studies indicating that if you don't get those early years right, even before kids get to school, there are long-term consequences. And just this research has major implications for policy. If I was an adult policymaker looking at this research, I would want to invest in prevention. I should just say, I was talking to somebody just before the talk, and New South Wales have just done their data on the cost of keeping one young person in youth justice, and it's $2,000 a day, $750,000 a year to keep one young person in social justice. And I think we could write a generic life course that would fit almost all of those kids. So even if you don't care about kids or young people, it just makes economic sense. And then social climate change. The conditions under which families are trying to raise young children are so different than they were a couple of decades ago. There's very rapid social change, life's more complex, there's social media, work is insecure, there isn't the stability of families we used to have, etc., etc. So for poorly resourced families, all this is really overwhelming. This is a quote from Dan Keating and Clyde Hertzman, again, over 20 years old. Modernity's paradox. We are witness to dramatic expansion of market-based economies whose capacity for wealth generation is awesome. At the same time, there's a growing perception of substantial threats to the health and well-being of today's children and youth in the very societies that benefit most from this abundance. And I'll leave it to you to reflect whether that's improved or got worse in the last 2 decades. And this is a great quote from David Green, again, a long time ago now, which sums up social climate change and the concerns we have about our children really well. quote, "It's not as if we've lost the knowledge of what has constituted a good childhood, but it seems more difficult to realise that in the context of rapid change. And we have limited ways of protecting, understanding, monitoring and controlling the impact of progress on children. Shared cultural, political and moral commitments to children are becoming confused, contested and weakened in the face of unstoppable changes, disruptions and uncertainty." So we really do need, I would argue, as a paediatrician and child advocate, to start trying to reduce the number of problems, to reduce the risk. And that in itself requires a paradigm shift in our thinking. Knowing there'll never be enough ambulances at the bottom of the cliff and starting to build that fence at the top. In other words, we have to start developing a prevention agenda. And the research is starting to tell us how to do that. Treating established problems is difficult, expensive, these wicked problems, and it's not sustainable. Economically, it's not sustainable. And the earlier we intervene, the better. And this is represented here. If we start to the left of this graph, the cost is low and the effectiveness is high. The longer we leave it, the cost goes up and the effectiveness goes down. So the evidence at a population level that we can fix entrenched problems simply ain't there. They're not scientific solutions, they're political solutions. And they're always measured in dollar terms. The next time you see any minister of any persuasion, left or right side of politics, asked about a psychosocial or welfare or health problem, listen to their answer. I promise you their answer will always be in dollar terms. We spent 10 million, 50 million, 8 million. The implication is that it's fixed. And I've not been successful in trying to tell journalists, don't accept that answer. Go on and ask them, what are the outcomes that you want for that money? And you'll find that if you wait for problems to become entrenched, the outcomes are going to be pretty poor. But at least that gets them through a term of government and gets us off the front pages. So the service system, we know, and I'm sure you know, is under very severe pressure. We see media reports of it every day, long waiting lists, again focus on prevention, on treatment. It's the old bushfire. If there's a bushfire there, we have to put it out. We can't afford the time on prevention. Major problems of access and equity, very fragmented. We did some work for the health department several years ago where we mapped all the child and family relevant services in Victoria. There are 147 different types of services, not 147 services, 147 types. So literally tens of thousands of programs and services for children and families. Very, very hard to navigate. And this is relevant to what I'm going to say before. Some services are dependent on a child having a diagnosis. If a child scores 6 out of 9, he or she hasn't reached the threshold, therefore isn't eligible for services, therefore the needs of that child just go wanting. And then there's rural disadvantage, of course. This is a slide of Medicare spending. You can see that total spending across the various SES groups is much the same. Primary care is much the same, but look at the difference here. The lowest SES tend to have a much lower rate of being seen by specialists. And this is the equity problem, that many, many parents can't afford the gap. So why aren't we doing better? I'm often asked that, I'm sure you are as well. Well, it's fragmentation, fragmentation, fragmentation. Fragmentation of advocacy, fragmentation of policy. There's vertical fragmentation between federal and state government. There's horizontal fragmentation between health and education and welfare. There's fragmentation within departments as well. There's fragmentation by age, different targets, etc. And then there's fragmentation in the service system as well. This is a project we did in Melton a number of years ago where we mapped the child's journey through health, education and welfare. And it's a complex slide because the child's journey is incredibly complex. There's multiple needs for assessment, multiple needs for a history to be taken, referrals. There's lots of duplication. You can imagine the inefficiencies. And these are all, Melton's a huge suburb now, so people have had to track all over Melton to get the services that they need. And this is work we did for Doveton College as a prelude to Doveton College being formed a number of years ago. We mapped all the services in Doveton, and there's no shortages of services there. The last thing Doveton needs is a new program or a new service. They need glue to glue together the existing service. So there's a lot of talk in the last decade particularly about improved coordination, about integration, at a whole of government, at a regional level. In an ideal world, integration or coordination would start at the top with government, with federal government, then state government, etc. It's really, really challenging. And this is the integration cascade from informal groups of individuals just informally talking to more formalised groups, co-location, sharing staff members, etc., down to ideally this shared vision, single governance arrangements, management, etc. So schools go some of the way down there, but not the whole way. But there's a network of community health centres around the state that do almost get to here. Single government arrangements, single employer, single management, etc. And one of the problems in this country, in this state, and one of the very unsuccessful advocacy issues that we've failed at, is not to utilise that better. So there's a network of multidisciplinary centres around the state who are seeing kids with problems. And we could and still should resource those properly and develop regional specialties there, because they are pretty well integrated. So, as I said, for a decade or longer, our centre has tried to do some work in this space, trying to articulate what does a child and family centre look like when it's integrated. And then we formalised this a couple of years ago under contract to the health department. Multidisciplinary team, clear referral pathways, all of these things are just self-evident. You know, you don't need a literature search and a formal document to do that, but we haven't been successful in convincing government to set these up around the state. So there are 3 new hubs as an outcome of the Royal Commission on Mental Health. 3 in a statewide system ain't going to cut it. Again, this edifice thing of building new things instead of gluing together existing ones. So there's an increased focus on schools. You know, we hear schools are getting overwhelmed with all the things that are happening. It's sort of exciting to see the commitment to schools and overwhelming at the same time. Schools are an ideal platform for child mental health and for health in general, because almost everybody goes to school. It's non-stigmatising, it's a universal platform. Experienced, trained professionals are looking at these children 5 days a week, however many weeks a year, and seeing them in those situations of learning, putting up their hand and taking the risk in the classroom, confidence, their interactions with peers, playground, etc. So what an ideal position to pick up kids that are starting to struggle at an early stage. And the structure already exists. We don't need to be building new community hubs. Every community has a school. So, and innovation's happening. These are some of the partial list of what's happened in the last decade or so in Victoria. Welfare coordinators, GPs in secondary schools, FISO, the menu. And the last 3 things I just want to touch on very, very quickly. This is a children's wellbeing continuum that we worked on for a year to land on these 4 words. And this is an attempt to start to address the stigma that lots of parents feel, coming to terms with the fact that their child may have a mental health issue, and really trying to get away from this need for diagnosis. So we want all children to have good mental health, obviously. Inevitably, as children go through life, there's going to be hiccups. There's going to be transitions and so on, where they're going to be anxious or get a bit agitated. We hope that they'll cope, and the role of parents and of teachers is to help build resilience, to help these children cope with the vicissitudes of life. But we also know that some children are going to start to struggle. And the goal is to identify those children that are struggling as soon as we can, and build scaffolding and supports around them to getting back to coping and not allowing them to become overwhelmed. And schools and school teachers, to my mind, are just perfectly situated to do that. And I'll come back and talk about that in a moment. The mental health in primary schools, Lindsay mentioned, this is a partnership between the Melbourne Graduate School of Education and MCRI, funded by the Victorian Government. And the goal is to train an experienced teacher to go into schools in a new role called the Mental Health and Wellbeing Coordinator. And their role is to work with a classroom teacher to build capacity, to delineate a clear referral pathway within the school and outside it, and build a whole of school approach to mental health. So we did a feasibility study a couple of years ago with 10 schools. It was feasible, teachers liked it, we could do it. Expanded to 26 last year, to 100 this year, and we're just planning for a rollout to over 400 schools next year, gulp, and then rolling out over 4 years to every single school in Victoria. So this is an exciting initiative. It's bold. It's a $200 million investment, so the stakes for us are obviously very high. As Lindsay said, I co-chaired the National Children's Strategy. There were 4 focus areas. You can see education is number 3, but family and community, the service system, evidence and evaluation, all 4 are relevant to schools. If we make school a focus, even of mental health, we get all of these in one hit, rather than to build new structures that don't exist now. This is a quote from Our Place, that many of you know, Doveton College. Evidence indicates that education is the key to lifting the aspirations and improving the lives of children and their families. Our Place facilitates partnerships that enable the school to be the central place for learning and support services that overcome the barriers to educational achievement. It's a nice succinct summary. So they don't fund any programs directly, rather they provide the glue to hold that system together. Support high quality environments, not just at school and in early learning centres, but also at home. Support the service system in prevention and early intervention, and drive better outcomes from the existing system. So they work with services in their area, demanding a more responsive and better service system. So in the old approach, 20, 30, 40 years ago, we used to focus on individual children and try and fix deficits. The whole point of working with children was, what's wrong with you? Here's how I can fix it up. Often very strict eligibility criteria. Sorry, you don't meet criteria for treatment because you don't get to the diagnosis. We only allocate resources when problems become so entrenched and so severe that we can't ignore them anymore. And as I said, the policy criteria is dollar amounts. And services are office-based. You know, paediatricians, speechies, GPs, we sit in offices and expect children to come to us. Well, that doesn't cut it anymore. There's a new approach that has a much broader population focus, a focus on prevention, early intervention, reaching out to families and focusing on outcomes, not process. So in summary, children aren't doing very well. As I mentioned before, this is the first generation of children and young people worse off than previous generations. There have been efforts in Victoria particularly to increase the capacity of schools to address those concerns. Community services are not fit for purpose. They don't resonate at all with the contemporary needs of children and families. There are major equity and access issues. And there are long-term consequences of continuing to ignore these problems in children. So I would argue we need organised abandonment of existing approaches and services and need to radically rethink how we approach children and families. I managed to find one of these temporary classrooms that have been temporary for, 30 years, 50 years now. But this is a good quote from June. Children and families should be able to flourish no matter where they live. And education really is the key to a prosperous life. And I love this quote from Yeats: education is not filling a bucket, but lighting a fire. Isn't that what education should be about? Don Berwick, who's a friend and a colleague, says nothing hard is ever easy. That what I'm posing isn't easy, but I would change that from a question mark to an assertion, a new leadership role for the education sector in helping to change that paradigm. Rather than referring children with problems out to a broken system, bring the system into you. Get the services working side by side with educators. And as I mentioned before, school's such an ideal platform for that, for obvious reasons. And reimagine the school as a community hub. And I'll just finish with this quote from Don Berwick. It's the burden on good leadership to make the currently unthinkable thinkable, to question the obvious, to make the present systems unavailable as options for the future. The boundaries in our minds create fear about the consequences of crossing over to the undiscovered country. But the possibilities we really need do not lie on this side of our mental fences. Once crossed, these fences will look as foolish in retrospect as the beliefs of other times now often look to us. Thank you very much.
Thank you, Professor Frank Oberklaid, for a fantastic presentation, and you can hear from the questions and the engagement has been extremely strong. So it's my privilege to offer the vote of thanks for your time. You've been much sought after as part of the Dean's Lecture series. So many of the points that we've raised through our questions and your conversation have really enforced to me and reminded me that we need to work in partnership. You've certainly said the words that all educationalists love to hear, which education is the key. We certainly believe that that's the case. There are many challenges for us to do that. The notion of schools being perfectly set up, it would be terrific if that was the case, but we know that in the midst of a crisis of retention in the profession, and a lot of that perhaps due to those new morbidities, not being well understood or well supported in terms of the teaching profession, that there are really big issues for us to be addressing. And so it seems to me that there's great work ahead that we can do together, and if I'm reminded of our pre-service teacher education programs and our in-service teacher education programs, but also of the blue sky thinking now, of the new roles that we need to have. So the idea that there are mental health and wellbeing coordinators coming in, I guess a question for us here is how are we really preparing for that? And I know, of course, many of my colleagues here at MGSE are working absolutely at the intersection of medicine and education. But there's a lot of work ahead for us to do. So thank you very much for this really insightful and provocative lecture. And if you could just join with me in thanking Professor Oberklaid.